Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event, and the focus of today's session is non-operating room anesthesia. Now, I would like to invite Dr.AL.Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical Colleges, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member president and state secretary of the ISA Tamil Nadu state branch. Now, without further any delay, over to you, sir. Thank you.
Thank you. I welcome all of you for the 42nd webinar of Puthukkottai Bhudhan Second Edition. The 41 edition was conducted last week under the topic anesthesia at a higher altitude. So the faculty from Regional Institute of Medical Sciences, Manipur participated in that. Now, this 42nd webinar, it is a good topic, that is a non-operating room anesthesia. What I want to convey, when I joined first year anesthesiology, DA, the next day I was asked to go for a bronchography, anesthesia for bronchography. Now bronchography is not being performed. So at that time I thought, area, it is actually half kilometer away from the department. So the area where the senior most anesthetist should go, a junior most anesthetist was sent. So now this Nora is very popular, and today we are having the youngest faculty, Dr. Harmitha Sagi. So Dr. Harmitha Sagi is a postgraduate. So she has done her undergraduation from Maharaja Institute of Medical Sciences, Vijayanagaram, where I went as a faculty. So now she is pursuing her second year post graduation in NRA Medical College, Visakhapattinam, and she is sharing the stage with the stalwarts, Dr.Amutha Rani, Nilesh, and Indubala. Sometimes the anesthesia webinar will become a matrimony. So this Dr. Harmitha is waiting to get married. So this will serve as a matrimonial column for Dr. Harmitha. So I wish all the very best for her and best wishes. So then it will be followed by Dr. Nilesh Naphade. Nilesh doesn't need any introduction. But even then, for the people who are not aware of Nilesh achievements, it is my duty to tell them. Actually, first of all, I want to say Nilesh is a good friend of mine. So that is the first introduction. And he is a founder president of ISA Kokan. And now he is a president of IMA Ratnagiri. And he is a secretary for Anesthesia Patient Safety Forum. So he is interested in safety aspects. And he is a national secretary for FAMCI, and he is a radiologist as well as an anesthesiologist, and he is a powerful business magnate. He doesn't aware how many CT scan and MRI centers he owns, because he owns a lot of CT and MRI, and he is a secretary AMC Ratnagiri. He is a trustee for Federation of AMC of India, that is FAMCI, and he is a member National Executive Anesthesia Patient Safety Forum. So he is always interested in safety. That is the reason why he is interested in anesthesia outside the operating room. He's a, as I said, he is a postgraduate in anesthesia and radiology. So he is actively practicing both the specialties. That is a rare combination. So he is a training faculty for CPCR workshops. He is instrumental in the formation of the first association of radiologists in Ratnagiri, and he has successfully completed a 5-day training mission to Tanzania. So in the auspices of Patient Safety Forum, he has established new branches of AMC in Tiruchirappalli, Tamil Nadu, and Sangli, Maharashtra. And I have visited both the places, Tamil Nadu and Sangli. So that is nice to see. So he's IMA National President Awardee for the best effective creative designs on digital platform, and he has won the Ganga Hall of Fame award. So every year, Dr. Nilesh will be in Ganga Hospital, Coimbatore for the GARG, and he is a Maharashtra ISA President Special Appreciation Award. Also, he has won. Many more awards are waiting for him. He is a workaholic, and he has written many chapters in textbook of anesthesia and regarding the patient safety. So he is interested in anesthesiology, radiology, and medico legal front. So to give a tough fight for this man who is having a tall stature, we are having Dr. Indubala Maurya. So Indubala Maurya is from Uttar Pradesh actually, but she knows Tamil very well, but she will say she knows only little bit. Actually, she was in Puducherry for 5 years. That is how she knows about Tamil, and now he is associate professor, Department of Anesthesiology, Kalyan Singh Super Speciality Cancer Institute, Lucknow. So he has qualified in MD as well as Diplomat of National Board, and she is a fellow in onco anesthesia and perioperative medicine. See, I am aged more than 60, but she is having publications more than 60. That is a great credit to Dr. Indubala. She has won many awards. So she is a university gold medal in a PG program. She has received a best reviewer award and received honorary fellowship of onco anesthesia. So necessarily he is an invited faculty for all workshops and conferences. She is associate editor, Indian Journal of Anesthesia, Airway, and Indian Journal of Pain. She is a great reviewer in IJA, Airway, JOAPM, JOACP, BMC, whatever journal you name, she will be the reviewer. And she is an associate editor in Indian Journal of Anesthesiology. So, Madam is a EC member, Indian Society of Critical Care Medicine, Lucknow, and she is a editor, ISA Lucknow, and she is a co-opted member of All India Difficult Airway Association, Lucknow. So she is having many membership. She is interested in onco anesthesia, airway management, regional anesthesia, focus, and research methodology. All the curricular activities we can digest, but very difficult to digest is she is having extracurricular activities also. She is good at drawing and painting and cooking. That is also possible. But she is a great dancer in Kathak. So Kathak it is a very very difficult thing. So she is tuned in that. But now she will make everyone dance to her tunes. So, Madam, we welcome you for the webinar, and we are happy to have you here. And then we were thinking to coordinate these great people who can do the moderator job. Then we thought actually the moderator is going to be Dr. Amutha Rani. She is Dean, Government Ramnad Medical College. So she is a past president of ISA Tamil Nadu. She is now a election officer in Tamil Nadu. So, Madam is a powerful personality in Tirunelveli. She is an emerging star from Tamil Nadu. She has won so many awards. So, she has received an award from Tamil Nadu Chief Minister for a good service in renal transplant, and she has received award from District Collector for specialized anesthesia services. She has received an award from Tirunelveli Medical College Dean for special services in anesthesia. So she has won the Proficiency Award for Best ISA City Branch. And Madam has won an award in 2020 March by Nellai IMA, Contribution to Women. She is a powerful vocalist for Women Doctors Forum. She has won COVID Warrior Award, President's Appreciation Award 2021, then award from District Collector Tirunelveli 2022, IMA Award 2022. If I mention the award she has won, the entire webinar will be over. So we have to cut short necessarily the awards she has won. So there is no other go. So I have to hand over the session to Dr. Amutha Rani. And many people have messaged me now after the introduction of Indu Bala and Dr. Nilesh. They are asking the phone numbers of both. So you will have many calls. So I thank all of you. Madam, Dr. Amutha Rani, it is your turn now. Please take it over.
Thank you, sir. Thank you for the elaborate introduction, sir. Welcome to Puthukkottai Bhudhan, the academic program which is being consistently and successfully conducted by the Dr. A.L.Meenakshi Sundaram sir, President-elect National ISA, and his team. He is a patron of Puthukkottai, and he has a very good team of ISA members who is helping him to conduct this program successfully. I welcome you all for this program. We will first start with, it's my pleasure to be with you on this 42nd academic activity of Puthukkottai Bhudhan. First, we will have the program. We will start the program with Harmitha Sagi. Shall we have Harmitha Sagi?
Yes, ma'am. Good
evening.
Yeah,
you can start the program.
Good evening, ma'am. It's my privilege to share the screen with such distinguished faculty. Today, my topic of discussion is on monitored anesthesia care. The monitored anesthesia care. The monitored anesthesia care is a planned procedure during which the patient undergoes local anesthesia, including infiltration or field block, and is mainly performed by a surgeon and together with the diagnostic or therapeutic support by administrating sedatives, analgesics, and or anxiolytics provided by the anesthesiologist, while continually monitoring vital parameters and being prepared to convert to general anesthesia if necessary. The monitored anesthesia care does not describe the continuum of the depth of sedation. Now coming to what are the advisory by ASA for responsibility of anesthesiologists during the monitored anesthesia care. The performance of the pre-anesthetic examination and evaluation and prescription of proper anesthetic care and personal participation in or medical direction of entire plan of care and continuous physical presence of anesthesiologist or resident and proximate presence in case of any emergency and non-invasive cardiocirculatory and respiratory monitoring, oxygen administration when required, and administration of sedatives, tranquilizers, antiemetics, narcotics, and other analgesic or other drug when required. Now coming to what are the preoperative assessment we'll do. It is the pre-procedure evaluation. In the pre-procedure evaluation, we'll have a performance of pre-anesthetic evaluation where we must take the keen extensive medical history to identify underlying medical and physical condition that may increase the risk during the monitored anesthesia care. And we must need to formulate a plan to decrease the risk. And preoperatively identify the patient with increased sensitivity to sedative, analgesic, old age, and if there is any obstructive sleep apnea and pulmonary hypertension. And there is a need of proper airway evaluation for assessment for any difficulty for ventilation, intubations, and identify the risk for the aspiration. And the appropriations for the monitored anesthesia care. It is to identify the airway and can be secured or not and level of sedation required and lighter levels in the patients where there is a limited access for the airway. And also there is a during pre-anesthetic evaluation, we need to assess patient's ability to lie motionless in position required for the procedure, such as in cases of essential tremors and cooperate if necessary in the patient such as cognitive dysfunction, dementia and extreme anxiety, and communicate with care providers such as verbal communication required during the monitored anesthesia care and conversion from monitored anesthesia care to general anesthesia, and when the patient is unable to tolerate or hypoxia or any and patient expectations. Now coming to indications. The indications are procedure related indications, whereas it depends the type of procedures such as minor surgical or diagnostic procedures, endoscopic procedures, and ophthalmic surgeries or radiological procedures. Whereas here the MAC is ideal for short, minimally invasive, painful, or anxiety-provoking procedures where regional or local anesthesia is used. Now coming to next indication, it is patient-related indications where the patient unsuitable for the general anesthesia and elderly patients and where the patients are anxious or uncooperative. And situational indications, procedure requiring patient cooperation such as awake craniotomies and short duration daycare surgeries. Now coming to techniques of monitored anesthesia care. The desired endpoints to provide patient comfort and maintain cardiorespiratory stability and improve operating conditions and prevent recall of unpleasant perioperative events. It frequently involves the administration of either individual or combinations of analgesic, amniotic, and hypnotic drugs. And there should be minimal incidence of side effects such as cardiorespiratory depression, nausea and vomiting, and delayed emergence, and there should be a rapid and complete recovery. If the level of sedation is deepened to the extent that verbal communication is lost, the risk of the technique approach those of general anesthesia with an unprotected and uncontrolled airway. Now coming to drugs. At present time, no single drug can provide all the component of monitored anesthesia care, that is both analgesia, anxiolysis and hypnosis, with an acceptable margin of safety or ease of titratability. Therefore, the patient comfort is usually maintained with combination of drugs, whereas the drugs used for monitored anesthesia care are the sedatives or hypnotics. These are the drugs induce a state of relaxation and drowsiness. Coming to the most commonly used drug, it is the propofol. In the propofol, it is very commonly used intravenous anesthetic agent for the monitored anesthesia care. Here, in the propofol, it provides rapid onset and rapid offset, whereas it is a no analgesic effect is seen with the propofol. Whereas with the propofol, there is a rapid recovery without any residual effect. And the disadvantages of propofol are it provides respiratory depression, cardiovascular depression, pain at injection, and requires careful monitoring and trainful person needed for the injecting propofol. The doses, whereas the propofol is given as a bolus for initiating the sedation, whereas later maintained as an infusion. For bolus, the dose of the propofol is 250 to 500 mic per kg bolus. The onset is about 30 seconds, whereas duration takes about 5 to 10 minutes. For the infusion, it is 25 to 75 mic per kg per minute as infusion. The onset takes 3 to 4 minutes without the boluses, and duration is about 4 minutes after discontinuation of the infusion. Coming to benzodiazepines, their benzodiazepines are the primarily used for anxiolysis, the anxiety reduction, and amnesia. The most commonly used benzodiazepines are midazolam, as it is a short-acting benzodiazepine. The dose of the benzodiazepine is 0.5 to 2 mg IV prior to the propofol, which is given over 2 to 3 minutes, as it potentiates the effects of other agents, and it may be repeated after 2 to 5 minutes. The onset takes about 1 to 2.5 minutes, whereas the duration is 10 to 40 minutes. As same as the propofol, the midazolam does not provide analgesic. It only acts as sedative and anxiolytic, and if given in repeated doses, prolonged effect or delayed recovery in older adults, obese or impaired hepatic function. Hence, dose modulation is required. The most common, the newly emerging drug is revimazolam. It is a new short-acting benzodiazepine. The metabolism of revimazolam is unique. It is by the ester hydrolysis, same as the remifentanil. The revimazolam acts as a GABA mimic. Hence, it is a new drug. Hence, more trials of its use are establishing for the monitored anesthesia care. Now, coming to dexmedetomidine. It is an pure alpha-2 agonist, and it is a more stable, and it produces a conscious sedation, especially in the patients with obstructive sleep apnea and respiratory problems, as it has a minimal effect on respiration. The loading dose of the dexmedetomidine is 0.5 to 1 mic per kg over 10 to 20 minutes. If given fastly, there is a risk of bradycardia and hypotension. The maintenance dose of dexmedetomidine is 0.2 to 1 mic per kg per hour. The onset takes about 5 to 10 minutes, whereas the duration is about 30 to 40 minutes. The dexmedetomidine, the advantages are it provides cooperative sedation, minimal respiratory depression, and good analgesic properties, and it acts as a sedative without any amnesia. Whereas coming to disadvantages, it is bradycardia, hypotension, and it has a slow onset, and it also has sympathetic rebound. Coming to next group of drugs, they are the opioids. These drugs provide pain relief. The most commonly used opioids are fentanyl and remifentanil. Coming to fentanyl, the dose of the fentanyl is 0.5 to 2 mic per kg IV, administered in intermittent boluses of 25 to 50 mics IV. The onset time takes about 2 to 3 minutes, whereas the duration is 30 to 60 minutes. Whereas the remifentanil, the dose is 0.1 mic per kg per minute, started 5 minutes prior to the stimulus. Whereas the remifentanil has a fast onset, about 1 to 1.5 minutes, whereas the duration is 3 to 5 minutes after discontinuation of the infusion. It also has a fast offset, and the offset is independent on duration of the infusion. Coming to the dissociative anesthetics, the ketamine is the most commonly used dissociative anesthetics. At the sub-anesthetic doses, ketamine provides analgesia and some sedation while preserving the airway reflexes. With the ketamine, the patient is conscious, coherent, oriented, but the patient is not aware of any pain or any surroundings. The dose is about 0.25 to 0.5 mg per kg IV, whereas onset takes about 1 to 2 minutes and duration is about 20 to 60 minutes. The ketamine provides a good analgesia. Coming to the next topic, the respiratory function and sedative hypnotic drugs. Here, the adverse respiratory effects of sedation administration include adverse effects on respiratory drive, airway patency, and loss of airway protective reflexes. There may also be marked increase in work of breathing because of increased upper airway resistance and adverse effects on respiratory system mechanics resulting from a decline in functional residual capacity. Here, the sedation and upper airway patency. In normal subjects, the tendency of upper airway collapse is opposed by an upper airway dilator muscle tone. They increase the diameter and reduce the compliance of the upper airway, which is reduced which are sensitive to the sedative hypnotics. And in sedation and protective airway reflexes, competent laryngeal and upper airway reflexes are required to protect the lower airway from the aspiration, which are further depressed by anesthesia and sedation. Coming to sedation and respiratory control, as the sedation is usually associated with depression of the respiratory drive. Supplement oxygen administration during the monitored anesthesia care. Hypoxia as a result of valvular hypoventilation is a relatively common occurrence following the administration of sedatives, analgesics, and hypnotics. In the absence of significant lung disease, the administration of only modest concentration of supplemental oxygen is frequently effective in restoring the patient's oxygen saturation to an acceptable level. Supplemental oxygen is usually required when monitored anesthesia care involves moderate or deep sedation or analgesia, as higher doses of intravenous analgesics and sedative medications can cause respiratory depression. Open delivery of oxygen by using nasal cannula or a face mask is a significant risk factor for operating room fire during procedures around the head and neck that require electrocautery. The most important aspect during the monitored anesthesia care is monitoring. Usually, we apply ASA standards where basic anesthetic monitoring are applicable to all levels of anesthesia care, including monitored anesthesia care. Here we have communication observation, which is further seen with scoring and pulse oximetry, capnography. Usually the capnography is most effective in intubated patients. It detects the hypoventilation during the administration of supplemental oxygen. The side stream capnography with the face mask, nasal airway, and nasal cannula is used with monitored anesthesia care. The cardiovascular system, it includes ECG and pulse either by palpation, oximetry, or auscultation, and temperature monitoring, and bispectral index monitoring. Usually, the bispectral index monitoring has a huge variability between the patients. Hence, thoughtful further role in the monitored anesthesia care monitoring is not established. Usually, during the monitored anesthesia care, we maintain the bispectral index about 60 to 80. Now, coming to the assessment scores by which we see the sedation level in the patient, they are as following. They are observer's assessment of alertation or sedation scale. Here, we see further response, speech, facial expression, eyes. According to it, the scoring is given. Usually, in the observer's assessment scale, as seen here, for the moderate sedation, usually in the monitored anesthesia care, we will maintain the score about 3 and 4. Whereas coming to the next scale, it is a modified Ramsay sedation scale. In the modified Ramsay sedation scale, usually by the glabella tap, we'll see the scoring. We'll see if the patient is awake or asleep. During the monitored anesthesia care, during the Ramsay sedation scale is about 3 and 4, where the patient is awake and responds only to commands. or either patient is asleep, brisk response to stimulation. Another scoring is patient satisfaction score. Now coming to the conclusion of the topic, the MAC is a technique that requires the presence of a qualified anesthetist as it is not free from any complications. The development of new TCI models allows to get safer mounted anesthesia care by obtaining the best drug concentration at the effect site. In the future, this development together with the correct patient monitoring will make mounted anesthesia care the first anesthetic choice in more and more surgical procedures. With the right monitoring and gentle touch, we can make procedures smooth and stress-free for everyone, both the patient and anesthetist alike. Thank you.
Thank you. Am I audible?
Yes, ma'am. Thank you, ma'am.
Thank you, Harmitha, for your nice presentation.
Thank you, ma'am.
As you all aware, nowadays, due to the medico-legal issues, many of the small hospitals and corporate setups are preferring an anesthesiologist for even small procedures. So, young anesthesiologists should be aware of all risks and protocols of monitored anesthesia care. Thank you for the elaborate presentation. We'll just move on to the next session. Thank you.
Thank you.
By
Thank
Nilesh.
you.
Dr. Nilesh, happy to have you on this session. Over to you,
Yes.
Nilesh.
Yes, thank you very much. And I will share my presentation.
Slides.
Okay. Should I proceed and should I start?
Yeah. It's
My
visible.
topic
It's
is
visible. You can.
Thank you. My topic today is Nora in radiology suits. So I have been given 30 minutes and I have some 63 slides to share with you. So I will dedicate less than a minute, half a minute to each slide. Here we go. So the usual Nora challenges. I hope for the residents and for the newcomers, NORA stands for non-operating room anesthesia. So these challenges are applicable to all NORA areas. So usual NORA challenges are unfamiliar spaces. We go and work in areas outside the operation theater. So those spaces, the rooms, the walls, the corners, the switches, everything is unfamiliar to us as specialists. There is an unfamiliar staff. Means we are not used to working with gastroenterology staff or gastroenterology assistants, radiology assistants, CT and MR technicians. So we are unfamiliar with the staff and the unfamiliar assistants. By unfamiliar assistants, I mean, if at all there is any assistant provided to you as an anesthesiologist, that assistant is unfamiliar with your requirements, your emergencies, your critical junctions, your demands. So you are unfamiliar with the staff and the staff is unfamiliar with you and your requirements both. There is no central gas pipeline and the cylinders are unreliable. What I mean by cylinders are unreliable is even in anesthesia setups, we are so particular with our cylinders, their valves and the spanners and all that. The same meticulousness and particular behavior is not observed by non-anesthesia specialty areas, which we call as NORA areas. Their cylinders might be left open, they are likely to leak, and as soon as you enter the NORA area, they tell you this is the cylinder and it's full. But you cannot rely on their opinion, and it's best that you know whether the cylinder is full or not. So these are this is a very common problem that you can't rely on their cylinders, and there are no central gas pipelines most of the times. Here I would like to give you one caveat to all my listeners that as you can see, the other celebrated guests and co-faculties who are with me are from reputed institutes and apex institutes and teaching institutes, whereas I am from a private practice setup. So most of the things which I talk about are likely to have a predominant imagination of private practice and the private setups of NORA and where anesthesiologists are called upon. The situations in apex institutes, teaching institutes, medical colleges is definitely better in terms of provisions, supplies, infrastructure, monitoring, and everything else. But yet, more or less, problems are similar. Those belonging to institutes and medical colleges, please excuse me if I make some statements and you feel that I have never seen this kind of situation, but believe me, 80% of the country today delivers anesthesia and medical services to people in private setups, which are always plagued by most of the issues that I'm going to discuss. So the fourth NORA challenge is there is no emergency crash cart in the NORA area. Unless you and your department has spent some time, energy, interest, and invested your ideas and seen to it that they have an emergency crash cart in private setups. None of the NORA areas, none of the radiology setups have an emergency crash cart. You have to have your own emergency drugs, or you have to see to it that the emergency drugs are prepared there or available there, at least in ampule forms, before you start the case. You need to be aware of some non-anesthesia and non-clinical prerequisites of that NORA area. In my case, because I'm going to speak only on radiology suits, let me focus only on radiology. You need to know the demands, the burdens, and the onus of the radiology setup. May it be CT, may it be an X-ray, may it be an MRI room. But you need to be aware about the non-anesthesia and non-clinical prerequisites of that. What are the demands from you as a practitioner? What do you need to do for the patient in that area, which are not directly related to our anesthesia service delivery. But you have to be aware and conscious about those prerequisites. And the last is, invariably, all NORA areas are crammed up spaces and there is crowding of people. In radiology, there will be a radiologist, there will be one or two radiology technicians. You will be there. There will be one ward boy or some assistant servant kind of person. There will be the patient, and the room will be crammed up with equipment and with wires, cables running from here and there. And you will not know which switch to use. All the switches must be occupied by the radiology department plugs and pins. So these are the usual NORA challenges. Now, when I am given 30 minutes to talk on NORA in radiology, I can split my talk into NORA challenges, NORA setup issues, NORA anesthesia drugs, what kind of NORA cases you will encounter, what are the drugs you can give to those cases. But in order to throw light on some different, unventured, undiscussed areas, I have decided to cut short most of the things in NORA drugs, NORA cases, how to conduct the cases. I believe all the listeners of this webinar are anesthesiologists who know everything about sedatives, induction agents, monitored anesthesia care, what they can give, what are the dosages. So I'm not going to spend a single moment on the drug dosages and bolus dosages and per kilogram dosages and all. No, I will discuss on certain other areas which I feel need to be reached out to each and every anesthesiologist, because the coming times are going to see a huge expansion in our availability and our applications in the NORA areas, particularly the radiology suite. So going ahead, the most common requirement of anesthesia in radiology is to immobilize a patient. I am very consciously, I'm underlining this. Most of the times, we are expected to immobilize the patient. Unless it is a CT scan of the chest or a CT scan of the mediastinum or the head, face, neck area, where they need to image the airway and the lungs and the mediastinum, and they want the respiration to be suspended or controlled. Unless this requirement exists, most of the times we are called in a radiology suite only to make the patient still. Now, the huge common is 95% of the times the calls sent to us are for, because it's a small child who always fears isolation, those cold air-conditioned rooms, the big machines, and hence becomes uncooperative and cranky. So you need to immobilize a child. Or it's a mentally challenged child or adult. So it's a mentally challenged patient who essentially requires to be immobilized to undergo the radiology investigation. Or it is a psychiatric patient who is unwilling to stay steady. You can't seek cooperation from such patients. And the patient is cooperative, but has extrapyramidal or involuntary movements, which is beyond the control of the patient. And such a patient has to remain still and steady for the investigation. Hence, you are called. A large chunk of the radiology NORA services from anesthesia are with the sole intent of immobilizing the patient. Now, if this is the case, then in all these cases, such patients rarely require a suspended respiration or a controlled respiration. As I said, if it is not a mediastinal mass, if it is not a lung mass, if it's not a chest CT, then we don't need suspended respiration, we don't need controlled respiration. I want to tell all the anesthesiologists that nowadays the faster CT scans, which have a very high and fast data acquisition, multi-slice, multi-detector CT scans, they are very fast, and they need the patient to have a breath hold only when there is a chest CT to be done. For example, if there is a patient who is a child who has a lower limb fracture and you want to do a CT scan or an MRI of the lower limb, in that case, what is the need for suspending the respiration of the patient? So it's not the chest, it's not the mediastinum, it's some peripheral body part, or if it's maybe some joint, then there is no question of controlled respiration, and hence most of them don't require an intubation. So intubation is required only in those niche cases where you need to control or suspend the respiration when the chest is being imaged. So if there is, let us presume that there is no intubation, then this is the most common formula that you can use any of these. You can use Dexmed alone, or you can use a Dex-Ket combo, or you can use a Ket-Midas combo, Ket-Compose combo, or any combo of your choice. All of them are good in order to immobilize the patient. And in that case, if the patient is well immobilized, you only have to put on oxygen through nasal prongs or a venti mask, monitor the patient well, look at the patient's respiration, keep observing the patient closely, be standing next to the patient in the investigation room. Don't be seated in the console room where the radiologist sits across the glass. Be in the gantry room, in the room where the patient lies and goes into the machine. Commonest errors in NORA radiology suites are patients are sedated and anesthesiologist sits in the console room. Console room is the room adjoining the scanning room in which the radiologist and the technician sit, and you go and sit there. Patients are sedated, unattended, unmonitored. Patients are not monitored or inadequately monitored. By monitored, I mean that you connect a good pulse oximeter, an ECG monitor. My prior speaker also mentioned capnography. So you need to monitor the patient in any which way possible, and whatever are the monitors at your disposal, but see to it that the patient's breathing, oxygenation, and pulse is well monitored. Oxygen is not administered as a protocol in every sedated patient. Now, this third bullet point is one of the most important, commonest error in NORA radiology suites. People believe what the radiologists tell them, that this is only 20 minutes, 30 minutes, 15 minutes procedure, and you feel that you need not connect oxygen. And when there is an emergency, you are found fumbling with the oxygen tubings and the nasal prongs or mask and oxygen cylinder. So I would strongly recommend connecting oxygen to every patient under sedation, whether you are in a peripheral center or in a district place or wherever you are. But these are the common errors of all the litigations that I have gone through. These are the commonest problems which have resulted in the loss of life or patients becoming seriously morbid. Patient becomes hypoxic in such situations, sometimes apneic, and both hypoxia or apnea goes unidentified, unattended, uncorrected. And the commonest cause of patient loss is poor monitoring. Believe me, in NORA, the commonest cause of patient loss is not incompetence of anesthesiologists, but it is poor monitoring. So I would like to give this very strong message to everybody. If you monitor the patient well, you are all good enough to manage the patient. You have all the drugs at your disposal. You have the laryngoscopes, tubes, LMAs, and everything to your disposal. You can ventilate the patient with a bag and mask. There is no possibility that we should lose a patient in the NORA area, provided you stand next to the patient and closely monitor the patient all the time that the patient is under your care. Litigations against anesthesiologists, if scanned, are dominated by NORA cases. I want to tell everybody that NORA is being discussed because NORA cases are expanding in variety, in numbers, and also in their the areas, specialities, different specialities, different hospital areas are delivering NORA cases. So anesthesia. So now I will delve deep into the NORA in radiology. Anesthesia in X-ray suit. This is how a typical X-ray suit looks. It is very often more crowded than what this picture is. But an X-ray suit anesthesia calls nowadays have dramatically dropped since bronchography, myelography, and ventriculography have gone out of practice. They have gone out of fashion. They are not done anymore. In fact, these procedures have been replaced by CT scan investigations and MRI tests. And so we frequent CT and MRI suits more than the X-ray rooms. If at all, anesthesiologists are called in X-ray suits or X-ray rooms, it is for contrast dye administration and monitored anesthesia care in case the patient develops anaphylactic shock or idiosyncratic reaction. So now I am entering into the realm of the current most important topic, that is anesthesia in MRI suit and CT scan suit. A larger part of my presentation I will dedicate to MRI because these are the places where most of the patients have gone bad, and our co-professionals have landed in courtrooms because of poor outcomes in MRI suits. We all need to know certain terms which are very commonly used in the radiology suits. This, as you all know, is the CT or MRI equipment. It looks more or less similar. It may be a circle or it may be a squarish, but it's a donut. And the central part is called as the bore. The bore is the hole in which the patient table travels. So we need to know all these words because this is a bore. And the round donut around the patient is called the gantry, in which the tubes rotate around the patient. So we need to know these words. For all those amongst us who don't know, please remember, this is the bore and this is the round around the patient. The mechanical donut is called the gantry. Now, accidents in MRI suits have occurred everywhere in the world. You must have read about MRI machines sucking patients, killing patients, and so many things. Look at this image. If you can identify the object which I have encircled with a red circle is an oxygen cylinder. Can you imagine as heavy object as an oxygen cylinder with its pressure regulating valve and the gauge and everything being sucked into the MRI and sticking to the magnet of the MRI because of poor attentiveness of the people delivering services. This is an entire bed which has gone into the MRI. This is a wheelchair and another equipment with its mounting system which has got sucked into the MRI machine. Such powerful magnets are used nowadays in the MRI machines, and they are all open magnets that even the ICU beds, in this image, if you can see the MRI or MRI bed on which the patient was lying has completely got crashed, and the ICU bed has gone and stuck to the MRI gantry. Such powerful magnets exist in the MRI machines. This is the most interesting case I have ever read in the accidents in MRI is the Sao Paulo case. Sao Paulo is a place in Brazil. What happened is that the patient was a lady and her son, who was a lawyer, had accompanied her to the MRI center. They were told to remove their watches, rings, bangles, and all metallic objects, belts, and everything. The lawyer said that yes, he has left behind everything, and entered the MRI room with a pistol or a revolver in his pocket. He did not disclose. He went into the MRI room. His mother was taken, and as soon as the 5 minutes into his gun got sucked into the MRI machine. The gun was sticking to the MRI gantry, and a bullet got shot, and the lawyer himself got shot by the bullet. He was admitted for a long time. He could not emerge out of that, and after a few days, the lawyer succumbed to that bullet injury. Now, can you imagine that the magnetic field of an MRI can suck a revolver out of the lawyer's pocket? The bullet, and not only that, the trigger got pulled and the bullet got shot at the lawyer. So such awry things can happen with metallic objects being carried into the MRI. Even today, despite an MRI being an old investigation, people being used to and hearing a lot of cases about MRI, yet accidents are still not completely difficult to imagine. we need to understand something called as missile effect and dangerous projectiles. I will request everybody to attend to these two terms. We need all anesthesiologists, we need to know what is the missile effect. It is an effect which comes into play in the MRI room. The missile effect is seen in an MRI room where ferromagnetic metallic objects are pulled into the magnetic field of the MRI scanner with a dangerously high velocity. This pulling of the objects into the MRI is called as missile effect, and that gives rise to another word term which is called dangerous projectile. Any ferromagnetic object that is forcefully attracted by the incredibly powerful magnet of the MRI machine, causing it to become an airborne high-speed projectile that has the potential to strike people or machines that come in its path, are called dangerous projectiles. Any object which is ferromagnetic in nature can get sucked towards the MRI with a dangerous speed, and any individual, any human body part or any machine or object that comes in its way, it will hit it mercilessly. All the objects that are seen on your screen can have the potential of being converted into dangerous projectiles. So you must also imagine your laryngoscope in the same row. What is a gauss? Please pay some attention to what I'm going to tell you. What is a gauss? Gauss is an older unit of measuring magnetic flux density, which means the strength of magnetic field. One gauss is equal to 10 raised to minus 4 Tesla or 0.1 millitesla. So Gauss is exactly similar to Tesla. It is the measure of the magnetic strength of the machine. What is a phi Gauss line? All anesthesiologists, we must know what is a phi Gauss line. It is a boundary within the MRI room beyond which the static magnetic field of the machine is considered weak enough for individuals with implanted medical devices and general electronic equipment to be safe, which means everybody, patient with a pacemaker, patient with a metallic implant, anesthesiologist with a laryngoscope or some trolley or a wheelchair is safe beyond the phi Gauss line. Now, which means that you should know in every MRI room where is the phi Gauss line. This is a picture of a typical 1.5 Tesla MRI machine. Can you see the brown painted area under the machine? That is the closest portion of the MRI machine, and that is called as the 50 Gauss line. Now, friends, this is 50 Gauss line because this is a 1.5 Tesla MRI. If this is a 3 Tesla, this could be a 200 Gauss line also. So, in other words, the magnetic field is most powerful in that circle. The outer circle is called as the phi Gauss line. The second line which encircles the machine in the room is called as the phi Gauss line, and outside the phi Gauss line is the safe low magnetic field area we all need to understand. To make this a little more simple, if the screen you are looking at, the computer monitor screen that you are looking at is the MRI room, this is the MRI machine, then this red area and the outer border of this red area is the 50 Gauss line or 200 Gauss line, depending on how big the MRI machine is. And the outer border of the yellow circle on the screen is the phi Gauss line. So all the areas outside the phi Gauss line are safe in terms of the magnetic field. We need to understand this because these are the areas where you can take ferromagnetic substances, otherwise not. Now comes the term MRI compatibility. What are MRI compatible anesthesia machines? They are machines specially designed to operate in an MRI room. They are certified to be safe in MRI environment. They are made from non-ferrous material which are resistant to magnetic fields. There is a big list of non-ferrous metals, titanium and stainless steel and many more. They can never become dangerous projectiles under the influence of magnetic fields. What? MRI compatible anesthesia machines can never become dangerous projectiles under the influence of the magnetic fields. This machine which you are seeing on the screen is a BPL Penlon Prima 451. This is a Penlon machine which is sold by BPL in India. Very expensive, but this is a completely non-ferrous machine. And this kind of a machine being available in MRI is an absolute luxury. MRI machines are of variable magnetic strengths. You must have heard 0.3 Tesla, 0.5 Tesla, 1.5 Tesla, and 3 Tesla. There are 7 Tesla machines also, not in India yet. So, as the number grows, the magnetic power of the machine goes on increasing. An anesthesia workstation safe in one MRI center may not be safe in another. Why I am telling you this is that if you have an MRI center with 0.3 Tesla machine, you have purchased an anesthesia machine for that center, telling the supplier that it's a 0.3 Tesla. Tomorrow you carry it to a 3 Tesla center, it may still get sucked because the magnet is more powerful than a 0.3 Tesla. So my recommendation to everybody is buy the complete set from one vendor, anesthesia machine, circle absorber, vaporizer, monitor. Don't source them separately because your anesthesia machine will be non-ferrous, but your circle absorber will have ferrous components or iron metallic components in them. MRI compatible anesthesia machines. I have written down I have taken good efforts to write down these sites. Please take a picture of this. The yellow window at the bottom is the cheapest 95,000 rupees anesthesia machine. This is in Indian. And the rest of the machines are 10 lakhs, 9 lakhs, 8 lakhs, 20 lakhs, and the sky is the limit. The 95,000 rupees machine most probably does not have a vaporizer. If you need a tech vaporizer with that, then that might add to the price. MRI compatible monitors. These are again the websites. I will request the viewers to take a photograph. I have given you 4 websites. Visit those websites and you will know more about MRI compatible monitors. People using TIVA pumps need to understand there are no MRI compatible TIVA pumps. So does it mean that you cannot use a TIVA pump in an MRI? No. The answer is no. You can still use TIVA pumps. The solution for using TIVA pumps in an MRI suit is called a Faraday cage. Please remember this term. It's called a Faraday cage. Today in India, B. Braun has come with a Faraday cage. There are many companies selling Faraday cages. Faraday cages are specialized MRI compatible enclosures or housings which allow the use of MRI non-compatible TIVA pumps in an MRI suit. Please understand, TIVA machines are still not MRI compatible. You use them inside a Faraday cage, it becomes compatible. The Faraday cages are designed to shield the pump and its batteries within the pump from the magnetic fields of the MRI and the MRI scanner from the pump's electromagnetic interference, causing image artifacts. So it helps both ways using the Faraday cage. This is how a Faraday cage looks. All the TIVA pumps are MRI non-compatible. Once you shut this door, they can work within the MRI. This model is served by Fresenius Kabi. It's called Agilia. It houses 4 TIVA pumps at a time. And this is another, I'm sorry for the poor quality, but as you can see, in one picture, the door is being shut. In the other picture, from the shut door, you can see the displays of the TIVA pumps. There are MRI compatible laryngoscopes. So see, there are people who supply certificates with laryngoscopes which are safe up to 3 Tesla. MRI, now these are common terms: MRI compatible, MRI friendly, MRI conditional, MRI safe, and MRI unsafe. But all these are very, very obsolete. There are only 3 terms nowadays. First is MRI safe, and this is the universal emblem of MR safe. Green colored and MR in a green square is a universal emblem. MR unsafe is red color, MR with a cross over it, and MRI conditional. What is MRI conditional? You can use that MRI conditional object in an MRI provided the conditions are fulfilled. Means you can use it with the 0.3 Tesla, not with the 3 Tesla. So those conditions if followed, that object is MR conditional. Look for these stickers on all the products that we use. There are MRI wheelchairs, and anesthesiologists amongst us who earn a living by working in NORA radiology, please buy these kind of watches. There are MRI safe watches available from all brands, including Casio and everybody. So you can have watches because if you're spending the larger part of your day in MRI rooms, there are MRI safe watches. This is a wireless, leadless, MRI safe pacemaker sold in India by Abbott. You can use this. Anesthesiologist also can require a pacemaker, and you will have to go into the MRI suit with this pacemaker. As you see, the pacemaker clearly mentions it is MRI safe. So if an anesthesiologist says that I thought there was no patient, so the machine must be off and the magnetic field of the MRI must be off, the anesthesiologist is ignorant about a magnetic field. I want to tell everybody, anesthesiologists should display high level of magnetic field literacy and understand Gauss lines, so that even if the Gauss lines are not actually drawn in your MR room in your department, you would know the energy of the magnetic fields related to the distance from the magnet. Friends, always remember all types of MRI machines, whether it's a resistive electromagnet, permanent magnet, or a supercon magnet, it should be presumed to be on at all times. In other words, the magnetic field of every MRI is active at all times. So don't walk into an MRI with a ferrous laryngoscope, because the laryngoscope is going to get sucked into the machine. Anesthesia in CT suit. I have finished MRI. I have very little time left. This is a typical prototype CT scan setup. On your right is the console room from where the machine is controlled. On the left hand side is the gantry room in which the investigation is done. Now, Can you stand here in this room and and look after the well-being of the patient? The answer is no. So either you stand here and look into the monitor of the patient, or you stand there behind the gantry. But the place behind the gantry is so tight that this is how we have to work. This is a photo I have taken, a very, very crammed up space. And if the patient's airway is to be monitored, you have to be at the head end of the patient. Then you have to stand in that crammed up space. The challenges of a CT suit are very different from an MRI suit. There are no magnetic fields affecting patients with implants, no gas lines, no fear of dangerous projectiles, no missile effect, no restriction on ferromagnetic substances being used in a CT scan room. But also, there are no specialized anesthesia equipment required, but there is a different set of problems with the CT scans. There is a space challenge, there is a radiation challenge, and there is a contrast media related challenge. Radiation means radiation is not there in MRI, it is there only in CT scan. It is harmful to the patient and to the anesthesiologist himself or herself. I hope everybody is aware there is no radiation in an MRI, but there is a lot of radiation in the CT scan. Patients and anesthesiologists of reproductive age need to be protected from radiation. These are a brand called Kiran, which has been bought over by Trivitron, a Tamil Nadu company, and these kind of fancy jackets which are protective are available. They are called lead aprons. They cost between 9,000 to 10,000. Different, whatever suits your fancy, you can buy. This kind of a lead skirt can be kept on the patient's lower belly if the patient is of a reproductive age and the upper thorax or head, brain, and neck is being scanned to protect the ovaries of the patient. In a CT, you cannot use reinforced tubes because they give rise to huge artifacts if it's a head, face, neck, or chest CT. Contrast related problems. This is a peculiar picture of a hyperosmolar contrast dry phlebitis. Now, osmolality of the blood is 290 milliosmoles per liter. There is an HOCM or high osmolality contrast media. The osmolality of that contrast is 2000 versus 290 of human blood. There is a low osmolar contrast or LOCM. The osmolality of this contrast is 90 milliosmoles per liter, and the most expensive contrast is iodixanol, which is isoosmolar. It is the same osmolality as blood. This is almost 4 times the cost of urographin, the regular contrast. When you administer these contrasts, you need to know this is a hyperosmolar dense solution. When you administer this, there is likely to be phlebitis, there is likely to be anaphylactic reactions, and iodine, all these dyes are iodine containing in CT scan. I'm not talking about MR. All these contrasts are iodine, have a potential of iodine related complications in thyroid storms. Problems with pediatric cases. Most of the times pediatric cases are what we are called for. There is no weighing scale, not available, and you have to rely on the weight of the patient mentioned on the patient's indoor papers. I would strongly recommend that you weigh the patients yourself. Only adult pulse oximeter probes are available in most of the CT and MR center. No pediatric probes are available. There is no availability of pediatric IV cannula, no pediatric masks, no pediatric ambu bags. I'm talking about NORA problems. I'm talking about the problems in a CT center where you're called for a child, but they have an adult ambu, they have an adult mask, they have an adult tube, and there is no post-procedure recovery bed to observe the anesthetized child. This happens very common in private setups. Probably they expect us to carry this with us. The single loud take-home message I want to give everybody who hears me today is the most essential prerequisite in a CT or MRI room is you must know how to terminate a scan and get the patient out of the bore in an emergency. You should have some pre-decided sign language to communicate with the people across the lead glass in the console room and declare an emergency. What happens is, now look at this. These are buttons on the machine. You press one button, the patient moves in. You press another button, the patient moves out. And you press 2 buttons together, the speed of the patient's movement becomes faster, inwards or outwards. You have to learn in the whichever center you are working, you should, as an anesthesiologist, should know which buttons to press and get the patient out quickly. If you see the patient is not breathing well, if the patient's color is growing pale or cyanotic, you want the patient to come out, do hell with the investigation. You should be able to deliver the patient out immediately. You don't have the time to call for the technician. He will come and help you. He will ask you a question. What happened? What do you want me to do? Is the patient serious? What has happened? What is the problem, madam? What is the problem, sir? No, don't waste this time. You should know which buttons to press and get the patient out. Have a hang of these buttons. Learn which buttons will help you to get the patient out. Because it is in these CT and MR suits, we are the only ones to understand that the patient is deteriorating and needs urgent attention. Even at the cost of interrupting the scan, go ahead and get the patient out. Nothing exceeds the importance of our patient's life, and nobody but we are the custodians of his well-being. I feel I've finished my talk. Thank you very much. I'm sorry I've exceeded my time limit by 2 minutes.
It's okay. It's okay. Thank you so much, Dr. Nilesh, for the excellent narration about Nora in radiology suit, with a lot of information that too from as a radiologist perspective. ALM sir is very brilliant enough to choose an apt person for an apt topic. As
Thank
you
you.
said, it is a vast topic. Nilesh smartly covered Nora in radiology suit. We can
Thank you.
take the question, all the questions at the end of the 3 speakers.
Yes.
Thank you, Nilesh.
Thank you.
I'll welcome Dr.Indubala Maurya. Really excited to hear about you, Indubala. The forum is yours.
Thank you, ma'am.
You can start. You can start.
Yes, sir. Thank you, ma'am. Good evening, respected seniors and dear friends. My topic for presentation is anesthesia for endoscopy procedures.
Go ahead. Go ahead. We are seeing it. We are seeing it.
Actually, that layout, I'll just check because my this is visible.
Rimpa, are you there?
Yes,
Yes,
now it's
ma'am.
okay. Yes, okay.
Can you help
Okay.
her out?
Sorry. No, now it's okay, ma'am.
Go ahead.
Yeah, you start.
My topic for presentation is anesthesia for endoscopic procedure. The brief outline is, after brief introduction, I'll just focus on GI endoscopic procedure, what is anesthesia goal, and anesthesia management in its complication. Few of the slide, actually it's a repetition from the previous speaker, they have covered very well. So what is NORA? Just to revise again, anesthesia care, if it is delivered outside the traditional OR setting, that is NORA. And now it is growing and number of different diagnostic and interventional endoscopic procedure is being done. And we are called for sedation or MAD for the patient comfort and procedural precision. Though we are away from the OR setting, but standard of care, monitoring and patient safety should be like operation theater room. These are the common endoscopic procedure. In GI endoscopy, it is upper GI endoscopy, lower GI endoscopy, both are being called for anesthesia. And besides that, airway procedure like flexible bronchoscopy and cystoscopy, hysteroscopy, also an endoscopic procedure for which we are asked for MAC or sedation or general anesthesia. I'll just focus GI endoscopy. Goal of anesthesia in endoscopy is just to ensure patient comfort and with ensure patient mobility to prevent sudden movement so a procedure can be done. And besides that, we have to maintain airway, breathing, circulation, and to facilitate patients' rapid recovery so that we can increase the turnover of the patient and we can discharge the patient as early as possible. All the challenges, what is there in radiology suite, it is also there in endoscopy suite also, because it is away from the OR complex, and if any emergency arise, it is delayed and space is restricted because of endoscopic cart and other equipment, manpower. We have limited access to airway and many time lack of equipment, trained staff who is trained for the anesthesia support, that is also there. And even emergency equipment, drugs, and it is not available when emergency crisis arise. But the person who is assisting you from the endoscopic suite, he may not be trained for that. And besides that, there is need for interdisciplinary communication during the procedure, because we may not be well versed with the what procedure they are doing and what are the different critical steps during endoscopy. In NORA location, always have minimal ISA monitoring devices like ECG, SpO2, NIBP, even ETCO2 temperature. And we should have working suction catheter, suction machine, catheter, oxygen supply. Besides that, we should have LMAs, ET, laryngoscope. We can, whenever there is a crisis arise for airway, securing the airway, we should be able to do it. We should have defibrillator, resuscitation drugs, and trained anesthesia personnel should be there in the vicinity. And we should always have a post anesthesia care area. This is one of the most neglected. Even well equipped area will be there, but there will be no dedicated space for post anesthesia care room. Because I am discussing with GI endoscopy, we should know what are different kind of procedure, what is the complexity of procedure and degree of stimulation, and what time there will be the excessive stimulation, and what will be approximate duration of the procedure, patient's position during the endoscopy, and any risk for airway sharing. First, like duodenoscopy, if it is just diagnostic endoscopy, this is endoscopic examination of esophagus, stomach, or duodenum. Mostly it is done in lateral position, or many a time supine position, just slightly tilting of neck. That also can be done. But because we endoscopist is sharing air with you, it may be difficult during the emergency, and there risk for gagging, aspiration, hypoventilation due to sedation, a laryngospasm during the upper GI endoscopy. Another advanced upper GI endoscopy is ARCP, endoscopy retrograde cholangiopancreatography, in which there is cannulation of biliary and pancreatic duct with wide view duodenoscope. It is primarily used for stone removal or dilatation and stenting. Majority of patients who are going for ARCP, they are already sick patient, critically ill, or old patient. And most of the endoscopists prefer prone or semi-prone position, though few can do in supine position also, but it is difficult for them to negotiate the endoscope and do the ARCP. And because this is kind of therapeutic one, and they are putting means like they are doing dilatation, stone removal, there are risk of bleeding and even perforation. Besides this, there are use of fluoroscopy, so there is exposure to X-rays. Colonoscopy, this is lower GI endoscopy. This both used for diagnostic and therapeutic purpose. It is primarily for biopsy, polypectomy, dilatation, or stent placement. It is done in left lateral position, but many a time, if it is difficult to negotiate through the flexors, patient need to be changed to the supine, then to the lateral position. It may be difficult to change the position in patient who is sedated, and we may have lack of manpower that we have to take care of, and duration may be from 15 to 45 minutes. Because these patients undergo bowel preparation before procedure, there may be possibility of fluid and electrolyte imbalance, especially old patient. That's why we should have clinical assessment for dehydration or hypokalemia in this patient. When there is insufflation of gas during colonoscopy, it will increase intra-abdominal pressure. There is chances of aspiration and vagal reflex causing bradycardia during colonic distension. Like all procedure, these patients should go for pre-anesthetic checkup without any shortcut. All clear medical history, including existence of any comorbid condition, cardiac or pulmonary history of drug allergy on any medication should be noted down and should be tailored off. And physical examination, a detailed airway assessment should be done at ASS stratification. Patient undergoing GI endoscopy, we need not to have any specific investigation, but we can review all the investigation what is available. But if you think patient is sick, critically ill, he's dehydrated, or maybe is issue with blood sugar, that we can ask for hemoglobin, blood sugar, or electrolyte before a day before procedure. And if you think you're not able to assess the cardiac status and ECG is not available, we can ask for ECG also, or echo, depending on the situation. It has to be tailored off. It is not uniform for all the patients. All patients must go for have a fasting as per their age, and bowel preparation may be done in the most of the colonoscopy procedure, even for upper GI endoscopy. All patients have informed consent, and all the risks associated with the endoscopy and anesthesia should be explained and clearly mentioned in the consent form. And patient may need pre-medication, antiemetic, or anxiolysis as per your institutional protocol. Anesthesia management. And now anesthesia management, what type of anesthesia we are going to take in this patient will depend on patient-related comorbid condition, factor, age, and procedure, what is anticipated duration with and position, what is the complexity, and resource availability. Many a time, if it is long duration procedure and your anesthesia machine is not available, you may go for TIVA, and it's our comfort also for which we are comfortable. That will all affect our anesthesia management plan. Airway concern, because in upper GI endoscopy, the area will be shared with endoscopist, so it is shared airway. And if patient is lateral position or prone position, so again, there will be difficult access to airway. And if there is a risk of aspiration, patient is especially going colonoscopy, or patient is having poor risk of aspiration just because of their other comorbid condition like diabetes or morbid obesity or gastric outlet obstruction, that patient also have high risk for aspiration. So always be ready for routine or emergency equipment. Anesthesia airway management, you can choose depending on your status or type of procedure being done. You can select from nasal cannula, face mask to endotracheal tube to even LMA gastro, depending on the type of anesthesia you have chosen. Patient with high risk for respiratory depression or obstruction, in that situation, beside nasal cannula, face mask, if you don't want to intubate the patient, you can use an IV ventilation or high flow nasal cannula also. Patient with high risk for aspiration, gastric outlet obstruction, achalasia, or bowel obstruction, or if these patients are undergoing procedure under a prone position or semi-prone position, better go for general anesthesia with intubation. If patient is having predicted difficult airway, already airway opening is less, or obesity, then again you have to tailor it off whether you want to go for tracheal intubation or you want to secure with LMA gastro or any other airways. These are few common airway gadgets which is primarily meant for endoscopy. First is endoscopic mask with endoscopic opening. And this is oropharyngeal airway with endoscopic opening with, you can put oxygen with this port and you can put suction with this port. This is with mouthpiece with oropharyngeal airway that can be used for endoscopic procedures. Anesthesia plan, few of the endoscopic procedure, healthy patient, relatively healthy patient, or who is cooperative, that patient, that endoscopic procedure can be done without sedation under local anesthesia. And some procedure which is primarily diagnostic, or some patient may be anxious, they need minimal or moderate sedation. And few may require deep sedation if it is longer and therapeutic endoscopy. And patient who are high risk, critically ill, patient in prone position, or procedure is long, then in that situation, we have to go for general anesthesia in this situation. What are the, as per requirement, as per procedure, diagnostic upper endoscopy, mild to moderate sedation is sufficient in most of the cases, unless patient is uncooperative. Colonoscopy, mild to moderate sedation, but advanced endoscopic procedure, GA or GA with intubation or LMA gastro, in advanced endoscopic procedure, it is primarily ERCP, endoscopic ultrasound, or esophageal structure dilatation, treatment for bleeding varices, or POEM. This is another upcoming one where per oral endoscopy myotomy is done. This requires, because it requires multiple attempts for endoscopic insertion and removal, and it takes time, maybe 2 to 3 hours also. So these situation we have to go for GA with intubation. Just to revise again, patient position we have to confirm either supine, lateral, prone, depending on the type of endoscopic procedure being done. And how we're going to choose the drugs for sedation and analgesia. Again, it will depend on patient factor, clinical clinician preference, means anesthesia team preference, and desired depth of sedation or anesthesia. This is again repetition of the first presentation, where we can use the combination of various drugs like midazolam, fentanyl, ramifentanil, propofol, dexmedetomidine, and ketamine. And besides that, antiemetic and glycopyrrolate, few people are using also glycopyrrolate to reduce the secretion during colonoscopy. For patient who can be done without any sedation, they can undergo topical anesthesia, pharyngeal topical anesthesia with aerosol spray, 10% aerosol spray, or lignocaine gargle, 4% is available with or without sedation. Many people tolerate for diagnostic upper GI endoscopy or colonoscopy. Again, propofol is the most commonly used, having rapid effect, side equilibrium, short elimination time. It has minimal residual psychomotor effect. Studies have shown patients are more comfortable in the recovery phase and satisfaction is high with propofol sedation. But it has risk of apnea because the therapeutic index is low, and patient maybe go from deep sedation to complete apnea. Many time it is combined with midazolam or opioids. Midazolam, it's many time it is used as anxiolysis as a pre-medication. It is used if it's mild to moderate sedation along with opioids. And it may have some concern with patient with old age and obese with impaired hepatic function because of delayed recovery. Opioid is also used with in combination with midaz or propofol to suppress cough and provide analgesia. Either fentanyl, short-acting opioid, or ramifentanil, which is short-acting, ultra short-acting opioid, which has a rapid wearing off. That either of two can be used, whichever is available. Ketamine provides dissociative state with amnesia and intense analgesia with minimally respiratory depression, and it is used in combination with midazolam, propofol. It provides it is ketofol is very commonly used in different proportion. That was good anesthesia and analgesia. Dexmedetomidine, this is sedative analgesic with some analgesic effect, anxiolytic and some analgesic effect. But it takes time, 5 to 10 minutes to have its peak effect. So we can start with midazolam, with bolus, with propofol, and then we can continue with dexmed, depending on your preference. Actually, it's you have a group of drugs that you can use in combination with your preference and your comfort. And maybe slight delay with recovery is delayed with in comparison to propofol, but overall recovery and discharge from the post anesthesia room is not affected. But there is risk for bradycardia and hypotension. Again, to emphasize, during sedation or GA in endoscopy room, always have always follow monitoring guideline, have continuous ECG, SpO2, NIBP. Capnography can be used even patient with mild sedation. You can put a nasal prong with side stream capnography, and in face mask also you can put with oxygen mask. Temperature, it is said to be as per guideline it is there, but if it's available you can use in especially pediatric patient, frail patient undergoing long procedure. And availability of anesthesia person for during the procedure is the one of the requisites for the monitoring these procedures. Besides that, how to assess the level of sedation? Different scoring systems are there. Whichever is comfortable, you can use. It's Richmond Agitation Sedation Scale. This is 10-point scale. Other Ramsey sedation, modified Ramsey sedation, or observer assessment sedation scale. Either of it, you should be aware of it, and you should able to monitor the depth of sedation in these patients, and you can titrate your drugs. Recovery and post procedure care. It should be, because many times we are so focused with main procedure room, we are not aware of how our is recovery room. It should be equipped with oxygen suction, and we should have some emergency drug to an emergency airway cart also available in the recovery room. Observe patient for airway obstruction, desaturation, vomiting, pain, agitation, hypotension, and patient can be discharged when vital is stable, and you use ALDRET scoring. If you more than 9, then patient can be discharged. And always all the procedure from starting from pre-anesthetic checkup, intraoperative events, and post-op discharge, just like we do in OR room, it should be documented clearly. There should not be shortcut for this, and it should be documented and put in the patient's file. GI endoscopy is not without complication. Majority of these complications is associated with anesthesia care, like hypoxia, regurgitation, laryngospasm, arrhythmia, especially patients having intense pain during sphincter manipulation or stricture dilatation. That time can have, because of vagal stimulation can cause arrhythmia, even cardiac arrest. Bleeding, maybe procedure related, because if you're doing ERCP, patient having coagulopathy, it can start bleeding also. Another fatal or rare complication is GI endoscopy has air embolism, though it is very rare, but it is very fatal. So all the management for air embolism is the same as for standard air embolism in any situation. If patient is having hypoxia, look for airway obstruction. If patient is over-sedated, do jaw thrust, ensure patient is receiving oxygen, do bag and mask. If needed, you have to put advanced airway. Laryngospasm primarily because of airway irritation with the secretion. You can deepen the plane, you can provide positive pressure ventilation. If required, you have to intubate the patient. Aspiration mostly causes inadequate fasting or reflux. In this situation, suction and intubation, and we have to continue to monitor the patient for pneumonitis. Patient with hypotension, bradycardia, primarily because of vagal stimulation or because of our deep sedation or propofol injection. In this situation, standard protocol of giving fluid, atropine or vasopressor. Arrhythmia, if it is because of hypoxia, treat the hypoxia. If it is because of vagal reflex, you can ask the endoscopist to deflate the colon and provide oxygenation and ensure there is airway is managed. In allergic reaction, standard stop agent and provide give epinephrine and steroid. These are just basic broad presentation for the patient undergoing GI endoscopy, but sometimes we get specific population like pediatric population. Again, we have to consider what are the physiological challenges with the different age group. Maybe if a child is 11 or 12-year-old, maybe he may be cooperative with some topical or some mild sedation to deep sedation, patient may able to tolerate the upper GI endoscopy. But if it is small child, because they are physiological challenges, we may have to go for general anesthesia even for a small and short duration procedure. Patient have high oxygen consumption, small FRC, there's increased risk for rapid desaturation, narrowed airway. So even patient desaturate, you have very less time for intubation and recover the patient. That's why better we should have lower threshold for intubate these patient. And if patient is toddler, many a time they have a separation anxiety. In that situation, parental presence or oral midazolam can be used for anxiolysis. And anesthesia management, again, depending on the patient's age and their how much they are cooperative and procedure, we have to go for sedation or more preference to GA with intubation. Another group is geriatric patient. Again, this group of patient has increased sensitivity to sedative agents and decreased metabolism leading to prolonged drug action and delayed recovery. So we have to titrate the drug and we have to lower the dose and avoid multiple drugs in multiple drug group in this patient and maintain normothermia and hydration. In this patient, post-operative observation is very important because sometime in post-op area they become agitated and maybe in delirium state. So it may delay a discharge from the post-anesthesia room. Just to summarize, non-operating room anesthesia for GI endoscopy is expanding, and we have to have same vigilance and level of monitoring and safety as operating room area. And choice of anesthesia depend on patient-related factor, procedure factor, and what is the infrastructure available in the endoscopy suite. And always each patient we have to use the tailored approach. All same drug, same idea for anesthesia management will not fit all the age group, and teamwork preparation is the key to prevent a complication. Always talk to endoscopic and have some idea about what procedure they are going to do and what is the type of stimulation, what is expected duration. Even if they say it is short duration time, but still you can ask what is the possibility of going to prolong and any complication, so that you should be ready for the advanced airway management. And besides that, if you have if you are getting NORA call in your institution once a while, still it is always advisable to have in close communication with those areas. So you should build up that area. If it is a routine, definitely slowly it gets developed. But if it is once a while, better those areas should be included for as anesthesia point of view, and invest some idea and have some equipment, crash cart, monitor in those areas also. These are my references. Thank you for patient listening.
Thank you so much, Dr. Indubala, for your wonderful presentation. You have covered all age groups from pediatric to geriatric. We'll see whether there is any questions or not. Thank you. I have to thank ALM sir, since he has invited me to the session as Nora non-operating room anesthesia, to which I have been attached for the past 10 to 15 years. I have delivered speech thrice in this topic in different forums. Thank you, sir. We'll see any questions are there. For first speaker, I think there is no questions. For Nilesh, there is one question. It is from Dr. Muthukumar Rajagopalan. He is asking, is there availability of MRI suits in India? That is interventional MRI suits
Yes.
in India.
Yes, but they are not therapeutic interventions. Only radiofrequency ablation is the only partly therapeutic intervention. Rest is all MR guided biopsy and all that only. No other corrective interventional procedures are done with MRI guidance. Most of the corrective interventional procedures are done in CT, ultrasound and X-ray intervention. But in MR, only biopsies, and if at all, some places there is radiofrequency ablation. That's all.
Okay. Thank you. Thank you for your answer. Is there any other questions? I would like to share my experience. While taking MRI to my father a few years back, I have mistakenly taken my handbag inside the MRI suit. That time I didn't know what will happen. But later, after a few days, I went for shopping. But none of my cards were working, either credit card or debit cards. That day I couldn't fix what is the problem. But I paid by my cash and went away. But after a few days, I myself, I have to replace all the cards. No, it was a big either. So that time only I came to know that is because of electromagnetic interference. All my cards were deactivated. That's my personal experience.
Even watches malfunction, they don't give you the right information provided if they are not MRI safe watches.
Okay. Thank you. You have given more information about MRI suits and CT suit. Thank you so much.
Thank you.
Madam, even that hotel room keys with
Yeah.
a phone, even mobile phone, it will not work.
Yeah, that we know, sir. That is because of mobile. That is also electromagnetic, sir.
I don't know. If you keep it by the side of the mobile phone, routinely mobile in the packet, so the charge will, again we have to recharge.
Yeah, that will not work. But I don't know what is the mechanism behind it. Either due to it is electromagnetic. Nilesh, if you can have an answer.
No, it is RF. They are all RF cards, radio frequency cards. And the phone signals that come, they are also radio frequency signals. So they botch up that radio frequency information in the card. So that information gets botched up, it does not work.
That is different from MRI suits. No, here there is electromagnetic interference in MRI suits.
Magnetic.
Yeah.
Nilesh, how
Rimpa,
much?
is there any questions?
Hello, Nilesh.
From chat box.
Your MRI suit.
Yes, ma'am. I'm just checking.
Yeah.
I have pasted one question, ma'am, over the chat box.
Which one, ma'am?
That I have answered, I think.
Okay,
already it has been answered.
Okay.
By Dr. Muthukumar Rajagopalan, right?
Yeah.
That has been answered.
Dr. Nilesh.
Yes, sir.
Yes, sir.
If Dr. Muthukumar has asked another question, if orthopedic implants are inside the body, what will happen?
Yeah, so the patient will be, I mean, if they are, what do you say? They are ferromagnetic implants, old times. Nowadays, all implants are titanium implants nowadays. So they are MRI agnostic. They are magnetic field agnostic.
Yeah, MRI suitable.
Yeah, so MRI suitable, compatible. But if you have those old ferromagnetic implants, then you will get that part will get sucked. If it's a 3 Tesla 3T machine, that is a magnetic field which is 20,000 times more powerful than the Earth's magnetic field. So that the patient's limb can get sucked to it. There are examples of patient getting sucked into the machine and got killed also. Nurses also have got killed into the machine, into the MRI machine. So 3 Tesla machines are very dangerous. So if you have an old implant, it's best you don't go for an MR.
Yeah.
What is What is the cost of your MRI suit with the MRI compatible bowel apparatus?
Sir, I don't have an MRI compatible bowel apparatus. I do all the cases without those which don't require intubation, only with monitoring and oxygen. And the cylinder I have kept outside, and only the tubings I bring inside and put a SpO2. There is, if the saturation is good, the case gets over very easily.
So as you are
Yeah.
having dual degree, which one you think economically viable? Radiology or anesthesiology?
By all means, radiology, sir, not anesthesia.
You know, anesthesiology is not trustworthy.
No, sir. Anesthesiology, trustworthy. Anesthesiology is my first love. I'm an MD in anesthesia. But the revenue which radiology churns, anesthesia cannot. And because there are other specialties interested in curbing the income of anesthesiologists, which does not happen with radiology, though that is also a referral dependent branch, but nobody engages in curtailing the growth of a radiologist the way they engage in curtailing the growth of an anesthesiologist in every town.
Correct words, Dr. Harmitha, to take it over. So I think, Madam, if there are no more questions, moderator can pass her final comments.
I think there is no questions. I think so, sir.
You can remarks.
It's an excellent presentation, excellent choice of speakers. It is hats up to you, sir. Everybody done their job very well. Thank you so much, sir.
Thank you. Now it is my duty to formally thank everyone. See, I am really overwhelmed because the minimum 800 attendance for Puthukkottai Bhudhan depends on the strength of the faculty. So this time I was a little bit jittery because I was in Varanasi and Dr. Nilesh was to arrange all the 4 speakers and suddenly he could not do it. At that time, I have some jokers. Actually, joker means they are not real jokers. They are the powerful card. The powerful cards, one from Tamil Nadu is Dr. Parswardi. So he's a powerful card. Whenever I could not declare Remy, I will call him. Then she said you contacted Dr. Indubala. So rescue man. Then another rescue man is from Andhra Pradesh, Dr. Praveen Kumar. So Dr. Praveen Kumar will never smile, never talk. He will only work. He is only work, nothing but work. He doesn't do anything, he will work. And he has picked up Dr. Harmitha. See, the wonderful point is, once I informed Dr. Praveen I need a postgraduate, he has messaged me the name of Harmitha. Then Harmitha messaged me, Dr. Praveen sir asked me to message you. Then one more assistant, sir, Praveen sir asked me to message you, sir. So it was full of messages, but Parth Sarthi, immediately he will locate the people. So at the outset, I thank these 2 people who are voluntary supply of the faculty. So we select the people who are really doing the job, and I'm really overwhelmed to see Dr. Harmitha, not as a postgraduate, she will become a super consultant in due course, because I was monitoring the way in which she has delivered the talk, and many people also monitored because I said that there is something else behind it. So I think our future will be bright. Minimum 800, madam, don't worry, we will give you the exact figures tomorrow. So we know Dr. Nilesh is a multi-talented person. He is a qualified radiologist and anesthesiologist. So we thought actually this program was initiated only for Nilesh because we has fixed one topic as CT MRI anesthesia, because most of the time Maharashtra, many deaths have happened in the MRI CT suit. That is the problem. That is the reason why we want that Maharashtra person. Unfortunately, he is a radiologist and he is an anesthesiologist. So I am happy my son is a radiologist. He has cleared the exams 2 days back only. So we will ask him to work under Nilesh. So Nilesh is good at insurance also. So he is a multi-talented person. That means he is a business person. Accidentally, he has become a doctor, but he is a good businessman. And really, Dr. Indubala is a very good choice picked up by Dr. Parsardi. So whenever Dr. Parsardi names anyone without any hesitation, we will take them into as a faculty. So I thank him also and Dr. Indubala the way in which he has enumerated The same way as Nilesh enumerated about the problems straight from the entry into the MRI suit. What are all the problems? See, gas lines and all, today only I am learning, for the simple reason we will not go for anesthetizing for MRI because that is a thankless job. And they will say payment will also be very less, risk will be more. And most of the time they will be having brain tumors. So they themselves suffer because of the illness. That is the education.
நீங்க கிளம்பலாம், இங்க இருக்கிற இடத்துல இருந்து இந்த மீட்டிங் முடிஞ்சிடும் நீங்க வர்றதுக்குள்ள.
With
முடிய
3
போகுது.
kg
சொல்ல போறோம்.
posted for MRI. Say I said that
அன்னைக்கு வந்து
even if you patient in surgery, it is not an issue. In MRI, if the death occurs, it will be a problem. So, Dr. Indubala, Scopy, I want to ask Dr. Indubala actually whether you have done any colonoscopy with spinal anesthesia.
No, sir.
Because routinely some sedation and this mask anesthesia is given, and she has enumerated as moderated set from pediatric to geriatric, and our madam serving dean, because now anesthesiologist taking up the role of the dean is a very big thing, and even her assistant, one more person is waiting to become a dean, and everyone now picks up the post of the administrator. So madam is one among them. So she's a rising star from Tamil Nadu ISA. We hope she will also come into the national scene soon, because she has the caliber and the subject. And rightly she pointed out, she is interested in anesthesia outside operating room. That is the reason why, in spite of being the administrative role, she voluntarily said, I will do it. Even if there is a problem, I said, you please come. If there is any hiccup, anesthesiologist will manage any situation. So somebody will take it over. So in spite of her tight schedule, that too with the northeast monsoon and so many infectious diseases are coming up, the entire state machinery is behind controlling dengue and other infectious illness. But we thank Madam for the participating as a moderator. Now with this remarks, I pass on the stage to Clarinet for their concluding remarks.
Thank you so much, everyone, for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, sir.
I will call everyone. Thank you.
Thank you, sir. Thank you, everyone.
Thank you, sir.